Hello, I'm Luiz Fernando Ybarra. I'm from McGill, and I'm in the CTO and Complex PCI fellowship program. And I'm going to present this case I did with my program director, Dr. Stéphane Rinfray. So, should be clear. Not going. Yeah, you went. So that's a 54-year-old patient with multiple risk factors, previous CABG, presenting with a stable angina CCS4. And that's his angiogram. So we can see the CTO at the RCA, some ipsy collateral going distally, and even some collaterals going to the left system. On the mid image, you can appreciate again OM CTO and LAD CTO with a subocclusion of diagonal. The last image, you can see a nice lima going distally to the LAD and some collateral going to the RCA. There was also a normal ejection fraction and 3 occluded SVGs. This patient was turned out to surgery in 2 different centers and came to our center. So our first procedure was supposed to be the RCA CTO. Our strategy was triple access for better visualization of the lesion, and that was a JCTO score 2. The thing is, pre-procedure, the patient developed hypertensive pulmonary edema. He went under general anesthesia and mechanical ventilation. Actually, the patient didn't take his medications prior to the procedure. He was very agitated. And our first angiography was performed 45 minutes later, but we already had the catheters in during this time. So that's our first angiography. On the left, you can see that the RCA is pretty much the same. However, when you see the left system, there's something wrong going on, and you can't really see the left main. We were somehow in a state of denial. Is it the disease progression? No, it's probably a dissection. What should we do? So that was not anymore RCA CTO we were aiming. Now it's a left main PCI or OM CTO PCI. So we attempted to wire the diagonal and the circumflex, big failure. In the meantime, the patient underwent cardiac arrest. We did a quick Impella CP insertion with no perclose. The patient was completely dependent. And we called the surgeons. They say they would graft the diagonal and the PDA. However, the marginal was not graftable. In the meantime, while the OR was prepared, we used the Fielder XT to fenestrate the left main. Here's the Fielder XT knuckling and fenestrating towards the circ. And a small shot can show that there was some antegrade flow into the circ. After advancing a pilot 200, we were very lucky to place this wire distally in the OM CTO. We were not aiming to this. It was really a lucky movement. And since we were there, we just performed guideliner stented strategy. And that's our final result after OM, circ, and left main stenting. However, we did lose the circ to RCA collaterals. They are not here anymore. We canceled the surgeon after heart team discussion. We did a brief attempt on the first diagonal. We failed again. And we still had the RCA CTO. The patient was still unstable due to the loss of the circ collaterals. So we went for it. At first, we did an antegrade wire escalation. Fielder XT again, Gaia, Pilot 200 didn't work. So we went for a dissection and reentry strategy with the Stingray balloon. Wasn't a really nice distal landing zone, but still we did try. But we are not able to re-enter with the wire. Should we call it investment procedure? Should we stop? Well, the thing is, the circ to RCA collateral improved in the meanwhile. The patient was needing less drugs and was somehow stable with the impella. And moreover, the procedure took already 7 hours and a high contrast load, almost a liter. However, the urine output was up to 40 liters. The patient was a minimal vasopressors. The echo performed in the lab showed the EF of 35, and impella had a good flow. And after 3 days, the patient had no pulmonary edema, normal creatinine, no vasopressors, and normal EF. So we judged for him to be good to go again. What would be our strategy for the second procedure? So for the RCA, should we go antegrade again? Retrograding. If we are going retro to the lima, to the epicardial collaterals, to the marginal collaterals, recanalize the LAD and use the septal collaterals. And what about the diagonal? Antegrade wire escalation plus or minus dissection reentry. For the technical aspects, we planned 3 axes plus 1 for the impella. So on the right femoral, we had the impella. On the right radial, we did a sheetless, 8-French sheetless technique to the left system. The left femoral went to the lima because he had a poor alignment with the left radial. And as we couldn't use the left radial, we went with a second puncture in the left femoral to the RCA. This seems a unique and innovative approach. Recently, I've been in Germany and in a center in Bad Krozingen, and actually that's their regular approach whenever they are doing they need a second access in the femoral. They don't stick the other side, they just do a second stick at the same vessel once they are sure that there's no peripheral vascular disease. So we were aiming for the first diagonal at first. Here is the wire going to we are trying to probe it towards the diagonal. However, you'll see that it somehow enters the septal. Could it be the septal? Yeah, we advanced the microcatheter, did a distal tip injection. Yeah, it was the septal. However, there was no visible connections towards the RCA. But still, we have the septal surfing technique, and we use the Sion wire to surf those septals. So here, advancing the wire, it's the wrong way, bring it back, advance back again. Yeah, it's the RCA goes all the way. It's a nice septal surfing. So after advancing the microcatheter, we did a small tip injection to make sure where we were. And after that, we planned a guide learner assisted reverse card. However, we were so unlucky, and the wire was actually in some kind of a ramus artery between the PDA and the PL. So we used the twin pass device to access both branches. And after stenting and bifurcation, all the chapters in interventional cardiology, we did the final injection, and that's the result on the RCA. So we already had the wire and the septals. We ballooned the LAD. We were very lucky because the second diagonal showed up. We didn't even know that it existed, and it was there. But our aim was the first diagonal, let's keep in mind. So we used the antegrade wire escalation technique, different wires, and finally the Pilot 200 went smoothly in the true lumen towards the first diagonal. You're going to see it going. And yeah, just sliding now, and it's true lumen. And again, after a guideliner assisted stenting of the first diagonal, the LAD and the left main with all the techniques, that's our final result in the left system. Remembering that we did the circ and then worm first, and now this diagonal, and the patient already had the lima to the LAD. But is the war over? And What about the impeller retrieval? Remember, it was quickly inserted. We didn't do a pre-close. Should we send the patient to surgery? Actually, we came up with this idea of the electro wire stripping of the impeller. What we did, we brought the impeller down to the descending aorta, and we cut the shaft of the impeller so we could insert a guide wire through it and gain access again to the vasculature. So that's the guide wire going into the right femoral, iliac, and it's up there. We brought back everything, exchanged for put an MP catheter, exchange for O35 wire, performed our 3-per close, and did some ballooning just to maintain hemostasis while doing the per close. And unfortunately, it's not showing, but we had a really good result in the end. So the patient was discharged 9 days later with a normal EF, normal creatinine, completely asymptomatic in a 9-month follow-up. He didn't have any symptoms. I actually made this phone call last week, and he resumed full activities. Unloading the LV might be a lifesaver. The impeller was a really helper on this case, especially in acute ischemic situation, as we had closing not only all the left system, but the collaterals going to the RCA. CTO techniques and skills may be applied in different scenarios. Remember, we had acute occlusion of both the diagonal and the circ, and we used our techniques on this. Take advantage of the hybrid approach. If you end for one lesion and you end up in another, just take it. Really be hybrid. Don't think only about antegrade, retrograde, wire escalation, dissection, reentry. Make it bigger and take advantage of where your wire is going and what you need to treat. Innovation and creativity may help overcome hard times and maybe surgery. And be resilient and don't worry, some days you have bad luck and others just good luck. Thank you very much for your kind attention.